Qualified, professional, and compassionate doctors talking real solutions to real health problems.
This message is from the Ministry of Health with support from partners.
Good evening, ladies and gentlemen, esteemed viewers and fellow healthcare enthusiasts. We welcome you to yet another riveting edition of the DOCtalk show, proudly sponsored by the Ministry of Health and its partners. I am Dr. Muyanga and your host tonight on the journey into the world of medicine, where we explore a number of topics, unravel mysteries together, but most of all, empower you with knowledge that will help you to take charge of your health. The elephant in the house tonight is chronic venous insufficiency. And in-house we have a special guest from Mulago National Referral Hospital, Dr. Kabweru Wilberforce, ready to do justice to this topic and to leave us with content and change lives. Dr. Kabweru, you are welcome.
Thank you very much, Dr. Muyanga. As already introduced, my name is Dr. Kabweru Wilberforce, and I'm a senior consultant surgeon, and I head the Department of Thoracic and Vascular in Mulago National Referral Hospital. So tonight we shall be discussing chronic venous insufficiency. I know it looks a very long, fancy statement, but simply it means the disease of the blood vessels, one of the diseases of the blood, of the venous system. And usually commonest, it is referred to by most people as varicose veins, but that is a section of it. But we also have other sections like reticular veins that may be a little smaller than the varicose veins, or telangiectasia that look like a spider.
Dr. Kabweru.
Yes.
You are leaving us a bit in the bushes.
In the bushes.
When you talk about terms like telangiectasia, which is even hard for me, a fellow doctor to talk about, it's a bit hard. So I think where we can possibly start from is people out there may not be knowing even what a vein is. What an artery is. Probably I think we should start by explaining what a vein is to my grandfather in Budumbuli back there.
Okay. So the veins are those are the blood vessels that bring blood back to the heart, and they are usually low pressure vessels, and they are close to the skin actually most of the times. So even when you hold your hand, those vessels that come up prominently, they are the veins. So this time we are talking about the veins of the lower limbs that are usually affected by this disease.
In other words, what you are telling us is that we have a number of veins or blood vessels within our body. We have blood vessels that take blood away from the heart to other parts of the body, which are arteries. And that's not the discussion tonight. Tonight, Dr. Kabweru is telling us about veins, which are blood vessels which bring back blood to the heart. But the veins we're interested in tonight are particularly in the lower limbs.
Yes. So when you hear about chronic venous insufficiency, it is a disorder that actually manifests on the lower limbs, whereby if we could look at how they are, the blood vessels are set within the lower limbs, we have those ones that are deep within the muscles, and then those ones that are in the close to skin or superficial, and then there are those ones that perforate through the fascia, connecting the superficial to the deeper system, but all aimed at making sure that they bring back the blood that has been used by the body, that has supplied nutrients, and now they have a lot of waste material that they need to come back to the heart and be moved out through the lung, through that exchange. So what happens with this condition, that actually that system seems to be down, or the pumping system fails. And we end up with the hypertension in those, how high blood pressures in the what? In those veins. And worst of all, the reason why it fails is that they are valves. Valves are like taps that allow blood flow in one direction. So when they fail, then there is that blood actually stays more down.
Dr. Kabweru,
Yes.
to stay together with you,
Yes.
one, you have told us that we have a pump.
The pump coming back. Helping
And
blood to come
usually
back.
that is because of the action of the muscles contracting.
Mm.
As they contract, they push the blood, they squeeze these veins
And
the
the
blood
valves allow the blood to go one direction.
And now we have valves as
Yes.
well. So when the blood goes up, the valve prevents the blood from coming back.
And then it goes continuously up to the heart.
So what you're telling us is in chronic venous insufficiency,
Yes.
the pump is failing
The pump fails,
and the valves
the
may
valves
also
also fail.
fail as
in
well.
most cases. So that's why you end up with insufficiency. Yes, and the blood now starts staying more or become, we could say, we call it stasis. It stays more in the vessels, and that actually causes a lot of challenges. And that may be one of the starting points where you start seeing signs and symptoms that people come with to the hospital.
Okay.
So that is what I could try to explain what that term means.
Dr. Kabweru,
Yes, sir.
would you mind helping us to understand the burden of chronic venous insufficiency within our society?
Within our
generally?
society. Actually, worldwide, this is a problem. If you could take like among 10 people, at least between 4 to 6 people have this problem. That's globally. Now, when it comes to our setting here, I want just to correlate it to our clinic that we run. Among 10 patients we see, roughly around the same number, 4 to 5 to 6 patients we see per every 10 patients. They have this chronic venous insufficiency that come to our clinic.
To 6 out of every 10 patients.
They have this. But that is now a clinic. So we wouldn't want to say that that is the same. If we extrapolate that into the community, that's what is happening to the community. But I know when we look at the risk factors, we shall realize that this is a very common thing. Sometimes they don't come full-blown as there, but they come with other symptoms, as we shall have a look at them. So it is a common problem.
It's really hard for someone to actually disagree with the statistics you have given.
Yes.
Because I am sure each and every person viewing us right now has seen someone out there either with swollen limbs or with swollen vessels on their lower limbs, or this person maybe has swollen vessels, swollen lower limbs, and probably has wounds as well,
and other
on the
things.
ankles or below. I think most of us have encountered that at one point, so I really wouldn't disagree with those statistics in any way. We thank you so much for listening in, and please take time to send your questions to the number that is posted on the screen, and we shall respond accordingly. Let us have a quick break and we return. Thank you.
This message is from the Ministry of Health with support from partners.
You are watching the DOCtalk Show. You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Welcome back from the short commercial break. This is the DOCtalk Show, produced by the Quiz Mali production and proudly sponsored by the Ministry of Health and its partners. Earlier we talked about the anatomy generally of chronic venous insufficiency. We talked about the fact that this is a chronic medical condition affecting veins in the lower limbs. And Dr. Kabweru shared a number of issues as well. So back to you, Dr. Kabweru. What are the possible signs and symptoms that can let me know that someone is actually having a chronic venous insufficiency?
Oh, actually, CVI, chronic venous insufficiency, sometimes patients may actually present as symptomatic without clear symptoms that you can easily visibly see. But some of them may present with a number of symptoms depending on the stage of the disease. And earlier on, a patient may just present with heaviness of the lower limbs. He can give you a clue that whenever I go for work and I come back, I feel my legs are heavier or pumped up or quite filled up than usual. Then when I rest, that feeling tends to subside. Others may actually present with edema. Edema means swelling. When they do either of the standing or the walking or any activities they do, their ankles, around their ankles, they tend to swell. And then when they rest, then also in the earlier days, it tends to subside, to go down.
How can I help my grandfather to understand the word ankle? You know, there are words we use at times, but the ankle, yes.
The ankle area is
because
that
you may think of an ankle actually relative. So what do we
So
mean
the
by
ankle is, you know, the foot is that
the part we plant down.
The part we put down. So as the leg starts, that one which moves up, that area there, that joint is called the ankle. Okay. So when you start swelling there and even along the leg itself, the leg is now that area that is usually between the ankle and the knee.
The knee, yes.
The knee. And then, so those are the areas that tend to swell. So when you have swelling of those areas, it may be one of the signs. But also other people can come in with itching. That leg itches them and it becomes uncomfortable, or pain, just pain in those lower limbs.
One of the studies we were discussing earlier,
yes,
that study actually talked about pain being occurring in 90% of the study participants.
Yes,
in that study.
That is actually called aching pain. That pain actually, people complain every time they do anything, they feel that aching pain. But also they may present with wounds, or what we call venous ulcers, and that is at the extremes. Or sometimes when they heal and they present with the scars, and also what is common is that they may also present with the skin changes. And one of the commonest skin changes is darkening of the skin on the leg, and it is uncomfortable because it keeps on building, and apart from that normal color change, that takes place, but also the thickening, that skin around that place becomes more thick than usual.
There is a way I think God decided to help out ladies in that aspect. That I've read up some studies, and actually I don't know why the darkening or hyperpigmentation occurs more in men than women, but probably we can go and research some other time.
Yeah, but I think it's because of the waste products contained within the venous blood that make those tissues actually change. And obviously that explains why we get most of those issues. And that blood stays longer there and it causes more trouble. So those are some of the symptoms. Now, which people are high at risk? Actually, they say that 90% of people who get most of these venous insufficiencies, they have either familial predisposition. Both the father and the mother had, so 90% of the children may have. Now, if it is only the mother who had, then that percentage is around 60%. But if it is only the father who had, then we get 25%. But also there is that history that even when there is no familial predisposition, 20% can always get this. That is from the hereditary point of view. But then We also know that there are people who do a lot of standing during their time when they are working, especially us, the health workers. We're also very prone.
Soldiers.
They are very prone. The
for
teachers.
health workers, I'm thinking of you surgeons.
Yeah, surgeons. Surgeons are more predisposed.
Okay.
Yeah, so somewhere, you may need actually to prophylactically you put on some things to prevent that exposure. But also, we know that business people who are ever on the move, traveling up and down, they are very exposed. And people also who do a lot of activities while standing most of the time.
Business people, what are we talking about?
The peasants who are always in the garden, standing, working the entire day.
Then we have talked about people like you who are ever on flights.
On flights.
As
those
well.
are the business
you
guys.
have a 10-hour flight,
yes.
20-hour flight.
Yes.
You sit from the start of the flight till the end.
So that is a very big risk factor. So basically, those are the people. And then obviously, we also get mothers who are pregnant or patients who have fibroids. Why do I talk about mothers who are pregnant? Remember, the uterus may sit on most of the big vessels that tend to drain blood from down up. So when that uterus is filled up with the baby, it sits on those vessels, and eventually blood cannot easily flow back, even when they raise their legs. So they're a very big culprit, and usually when they deliver, we give them some ample time, and that resolves.
It's actually a very common complaint among pregnant mothers.
Yes. So when they come, please, you send the patients to us, and then we talk to them. And then the other people also that are very affected are the patients who have a lot of either pelvic injuries, and injuring some of those big vessels, they can be involved, and then ladies who have a lot of fibroids. Leave these fibroids that are 1, 2, 3, but someone's uterus is all eaten up by fibroids and it's quite heavy, so they actually fill up the whole pelvis and lie on those vessels, and eventually you find that they are predisposed.
So, what you are telling us, you've talked about pelvic injuries, you've talked about pelvic masses, talked about pregnancy. So anything that compresses the veins that are returning blood from the legs back to the heart can end up with chronic venous insufficiency.
So even patients who actually get injuries to the vessels actually stand a chance of getting this chronic venous insufficiency. It's not the commonest cause, but it does have years later, after this exposure, you can end up actually getting chronic venous insufficiency. So those are the commonest. But others may just suddenly develop without any predisposition, and they present to our clinics.
What you have given us so far, you've talked about genetics.
Yes.
Then you've talked about pregnancy.
A lifestyle.
You've talked about someone having an intrapelvic mass. You've talked about a pelvic accident. You've talked about lifestyle. So from what you have said, literally,
it is wrong with us.
Everyone who is watching us right now can fall a victim of chronic venous insufficiency. So I think if we were about to switch off, we should sit back and listen more intently so that we take better charge of our health. Dr. Kabweru,
yes,
so you have listed for me the risk factors, listed for me the causes. Is there anything else you can add to the causes?
To the causes? Actually, those are the commonest causes, and although I want to also rule out the other myth that people have. People think when people breach, then they are more prone to develop this chronic venous insufficiency. No, but when you breach, you're actually prone to get skin cancer. So wouldn't wish. But I know when we talk about visible vessels, and then people look at those people who are breached, and they see those vessels, they think those are the vessels we're talking about. These ones have gotten issues, and we make a diagnosis by by carrying out a number of imaging modalities to confirm. So it is not by, obviously I know there are those ones that come with visible vessels. They are quite huge, tortuous, and obviously seen by everybody that they are not usual. But those ones that are small and whatsoever, those are not the ones that are very common, that are a big problem.
There is something I have kept thinking about. Bodybuilders. There are bodybuilders I've seen, and they have those typical tortuous vessels you have talked about. It's not only on the upper limbs, but even the lower limbs. Is there a possibility that they could also fall victim to chronic venous insufficiency?
I wouldn't want to allude to that. Actually, bodybuilding is one of the predisposing factors, because as much as they have those big vessels along them, we usually do serial duplex scans to assess whether their systems are still patent and they are okay. So apart from a few who may come actually, who may be identified, but that shouldn't be some models why that when I go to do bodybuilding, I will end up having chronic venous insufficiency. No, but they're also prone to other diseases that are different from this.
Interesting. Thank you so much, Dr. Kabweru. We shall be back, but kindly send any questions you have concerning this topic to the number displayed on the screen. You can also send the questions to our Twitter page as well as the TikTok page, and we are streaming live as well. Thank you.
This message is from the Ministry of Health with support from partners.
You are watching the DOCtalk Show.
Oh, you like to know, stay fresh. You wanna compete, tell you be my get. Lighting. Lighting. I did make a light to know.
Ituba Uganda is here, the new licensed operator of the Uganda National Lottery. They have been appointed by the National Lottery and Gaming Regulatory Board as the official operator for a 10-year period, based on their operational excellence in other regions of Africa.
The National Lotteries and Gaming Regulatory Board is dedicated to ensuring that the lottery is transparent, well-managed, and generates substantial revenue for national projects.
Ituba Uganda was selected through a rigorous process for their proven experience, financial stability, and capacity for successful lottery operations.
Ituba Uganda will utilize advanced technology and expertise to offer an unmatched gaming experience for Ugandans. All funds will support vital government initiatives such as infrastructure, education, healthcare, and sports, with a special emphasis on preparing for AFCON 2027.
So, join Ituba Uganda on this journey
of changing and transforming lives.
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
We had a discussion about people who are at risk of suffering from chronic venous insufficiency. So if you are a teacher out there and you stand for long hours, you are a doctor, especially surgeons, and you can stand on table for 4 hours, 5 hours, 6, 8 hours, or even 10 hours in some complex surgeries. You are a long distance truck driver. You are a businessman. Yes, you have your money, but you have to sit on flights for 10 hours, 15 hours, 20 hours. You are not free from the risk of chronic venous insufficiency as well. Dr. Kabweru.
Yes, sir.
So we have got to know about what I can look at to know that someone may be having chronic venous insufficiency. But how do we diagnose this condition?
Thank you very much. our viewers and Dr. Andrew. Diagnosis of chronic venous insufficiency starts with history taking. So the patient appears in the clinic. We take a number of details about whatever signs and symptoms she or he has. And also in that process, we are trying to rule out other possible causes, because not everybody that comes with swollen lower limbs, the problem is chronic venous insufficiency. Yes. So some of them may be having other cardiac lesions or kidney problems or liver problems. Other the duration, for how long he has been feeling those symptoms or having those symptoms and the signs. And then also we go on to assess. We examine. And when you're examining, you don't examine the lower limbs alone, you examine. Because some of the causative things that we have been discussing, you'll find out why he's even having those problems.
Yes.
So now that can give you 80%, 80 to 90% more confirmation that, oh, this is most likely chronic venous insufficiency, and the most likely cause is this. So, or sometimes you may miss out. But now, the other 10% we want to confirm.
You know, you raise a very critical point when you talk about us not just examining the limbs alone, but examining other systems as well.
The entire patient.
So in case you have this challenge and a doctor ends up is examining your heart or is maybe checking whether your liver is functioning well or your kidney, do not think that they are going off mark actually. There are things we need to rule out or things we need to rule in, which may be contributing to what? To the ongoing problem as well. Yes, Dr. Kabweru.
So I just want to continue and say that a number of tests, we may do general tests that are known to everybody. You do blood tests and whatsoever, or you do urine. You want to rule out whether the kidneys are okay, and then you do abdominal ultrasound scan, and then the rest. But the most confirmatory test that we do is more of imaging, and it is commonly called a duplex scan, and that will give us more details about the structure of the deep venous system, the superficial, and then the perforators. And also it will give us at different levels, at the foot level, ankle, and then that leg, and proceed up in the what? And the thigh up here. So that duplex scan gives you the anatomy, and then even how the vessels are functioning, and then even any other challenge that it may be identified.
Dr. Kabweru, you have left us.
Yes.
When you use the word anatomy.
Structure.
Yes, wonderful. Yes. So you are saying the duplex helps us to fully appreciate the structure of the deep veins.
Then those ones that connect
the superficial, and then those which you called the perforators, the ones that connect the deep and then the superficial.
And how they are working. Even those valves in there. So it shows the entirety of how that system works. Now, if that system has any problem, we would call it a problem, like until it manifests like this. Then it will pick for us at different levels. It will even tell you the grading, that this problem is just beginning, or it is moderate, or it is even severe. Yes. So that at the end of the day, when you make that diagnosis of chronic venous insufficiency, they can tell you it is mild, moderate, or severe. And you can now know. And also, it also gives us that confirmation if we are to do any surgery, where to intervene. So it is a very good diagnostic tool that actually helps us. I know there are a number of other tests that may be done, but I've just left them apart and just zeroed on that very important one. Okay. It takes time. When they are doing that, is all over hours, when they usually ask you to sit and stand up as they are doing that scan on the limbs to assess whether there is insufficiency or reflux, whether those, could I call them, the valves are still working,
the valves,
or they are failing. So when they are doing it, it may feel uncomfortable, but it's very important. And usually if we are planning to operate you, that is one of our tests that actually we need to actually depend on to make that decision.
Okay.
And so it gives us a lot of details that we sit as a team, decide, and say, I think this patient would benefit from no surgery, this one will benefit from surgery, this one can wait and watchfully follow up the patient.
Okay. Wow, interesting. I imagine a patient coming and the veins are visible superficially, but then from what you have said, you do the duplex, ultrasonograph, and actually find that this problem is mild. It's not something you should operate on per se. I think this helps us to better appreciate that not every condition, not everyone who presents with chronic venous insufficiency actually should be operated on. I think Dr. Kabweru will enlighten this issue during the section when we are talking about them. But for now, Dr. Kabweru, what are the possible complications that can happen within the context of chronic venous insufficiency?
Actually, one of the biggest or commonest complications of chronic venous insufficiency, I will leave some, but I will go to those ones that commonly occur. As blood stays longer in those vessels and it fails to drain fastest, it ends up actually making some clots. So one of the biggest challenge may be DVT, deep venous thrombosis. Those are clots, blood clots, and they become a very big problem.
Dr. Kabweru,
yes,
I think let us slow down on that because that is a key point. You have said that when blood is stagnant, if I may use that word, not stagnant moving the way it should move, chances of it forming clots are actually very high.
And where they form most of those clots are the deep venous system, rarely in the superficial, but also sometimes, but the deep venous system. And that's why we use that term, deep venous thrombosis, or clots in the deep system. And obviously, if they are there, they cause a lot of discomfort, pain, and whatsoever. And obviously, they are very dangerous when they move. Because when they move from down there and stop in the lung, someone just dies. So when it happens, we should see those patients and manage them. And the good thing that this is a manageable condition, it is easily diagnosed, and you put on medication, and most of the patients improve. And after they have improved, then we can plan to do other interventions. But when it is there as a complication, we have to manage it completely. And we can't do any intervention until it is sorted.
So, Dr. Kabweru, I think I need my father in the village out there, or any of you out there, to understand what Dr. Kabweru is saying. When he has said that one of the complications we fear most is deep venous thrombosis. That is a clot forming within the deep veins in the leg. That this clot can get dislodged over time. It can end up in the lungs, and someone has difficulty breathing and all sorts of problems.
And dies.
It can also end up in the brain at times, actually. In a few cases, it can happen, and you end up with a possible stroke. So this is
very important issue.
Very important.
And then the other commonest complications that we have seen patients coming with those chronic wounds that don't heal.
Dr. Kabweru,
yes.
The issue you are raising is so important,
very clear,
and I want us to do it justice. So I'm requesting our viewers that we have a short commercial break, and we come back and continue with this discussion. Thank you so much.
This message is from the Ministry of Health with support from partners.
You are watching the DOCtalk Show.
Nyati Motion Pictures brings you to Kopamoja, Uganda, the making of a nation.
Uganda, as we see today, never had a name.
Uganda is something that was created by the British, and they stole a letter B from Buganda.
The battle for protecting the sovereign Uganda was lost in Dokolo.
Uganda, fortunately for us, is a confluence of all these races, the races of Africa.
Genetically, we are even similar people.
We are one. Use that word, Pamoja.
Premiering on the 1st June 2024 from 3 p.m. to 8 p.m. at the Ndere Center in Ntinda. To get a ticket, call 0778 787 660. Tuko pamoja?
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Welcome back from the commercial break. This is the DOCtalk Show, proudly produced by Quiz Mali Production and sponsored by the Ministry of Health and its partners. Dr. Kabweru,
Yes.
we were talking about another complication of chronic venous insufficiency. The last complication we talked about was DVT, and I left you talking about venous ulcers.
The venous ulcers actually are very common. They usually appear on the lower limb, that's on the leg, and sometimes actually patients have tried to treat those wounds with I could say a variety of modalities, including herbs. The herbs have failed, including very good other modalities. They also fail, or when they heal, after being looked after very well, they always come back. So they are just an indicator that actually the causative agent for this wound is not yet sorted out. And what does it mean? It means your vessels still keep leaving a lot of waste in there that keeps breaking down this wound that is healing. So we usually, if the wound is very clean, we proceed and operate the veins, and after operating those veins, that wound heals for good. But if the wound is very dirty and whatsoever, and discharging a lot, usually we refer you to the plastics, to the doctors who are called the plastic and reconstruction, usually are very good at wound care, chronic wound care. And sometimes when we talk about chronic wound care, this is a wound that will be looked after for some months.
A reasonable amount of time.
And sometimes before they do their, sometimes they may even actually need to do skin grafting because the place that is uncovered is quite huge. But still, we need to work with them. We work with them in tandem so that, again, after the skin grafting, their graft doesn't break down. So we work with them and operate the vessels, and then they do that later on sometimes. Or we can do it at the same sitting, we remove the other and then...
Interesting.
Yes. So that wound is very interesting in that area, but the herbs don't work.
Interesting. So for our viewers out there, if you are having a wound on the lower limbs, especially mostly mostly around the ankle area, but even the rest of the leg, which heals and then comes back, heals and comes back, and you've tried all sorts of treatments, probably you may need to pay our specialists in Mulago a visit to be sure that actually you are not dealing with chronic venous insufficiency. Dr. Kabweru,
yes, sir.
What other complications?
Those are actually some of the commonest complications, but also the other things that don't come back, that is skin thickness and the skin changes may not actually resolve, and they remain dark for some good time. And I know most people wouldn't wish to have those dark limbs for the entirety of their lives. But those two are the biggest complications.
Those are cosmetic challenges.
Yes.
Interesting.
But to some people, that may be very big. If you went to someone who is a designer or somebody who keeps on showbiz and whatsoever.
You're a designer, you are a model.
A model.
You are a beautiful lady.
That becomes the area of concern.
A handsome man.
That becomes the area of concern, actually.
Okay. So, Dr. Kabweru,
Yes, sir.
I have come to you, you have taken history, you have physically examined me, and you have done the duplex ultrasonography and confirmed that I actually have chronic venous insufficiency. How do you manage me?
Management actually depends on the stage, and we do, there is medical management, then there is surgical management that we may conduct, and depending where you are, also may determine what kind of medication that you may get. Some of the drugs we give actually are not geared at resolving the vessels themselves, but I think they are geared at preventing complications and preserving what we have. So some of the drugs may help in breaking down the clots, if need be, and then some actually may help in making sure that that limb continuously remains viable. Meanwhile, also we reduce on the complications. So some of those drugs may not necessarily prevent. But also there are non-pharmacological modalities. We may not actually use drugs all the time, but we may use the comprehensive stockings. And those ones help to compress the vessels so that they facilitate the blood to go into the deeper system, and then it keeps moving. Sometimes actually we ask people to elevate the limb. You reach home, raise your legs above your belly as you're seated, and after some 30 or 1 hour, they actually feel relief. So those may be temporary measures. But then, if these symptoms no longer respond to most of those modalities, now that's when we do surgical interventions. And depending in which country you are, like Uganda, the commonest interventions actually that we have in this country is radio frequency ablation, whereby you introduce a sclerose and some drug in the vessel, and then you hit the rod that is in the vessel. Sometimes people may call it boiling the vessel, but it is just heating up the content in there so that it seals eventually with time. The success rates are high, but also the failure rates happen at around 7%. 7%. Yes. Now, the commonest that we do.
You are saying that particular modality work is 93% successful approximately.
But otherwise, it can also recur. Now, the commonest we do for most of those visible vessels, we do venous stripping. We cut out that vein from the greater saphenous vein is the commonest, and then the smaller saphenous vein. So we actually...
Dr. Kabweru,
yes, sir.
You are leaving us. You are leaving us.
Yes, sir.
Greater saphenous, lesser saphenous.
Okay.
Simplify for us.
Okay. Those blood vessels that bring back blood, there are two main ones that are superficial.
Yes.
There's a smaller one and a big one.
Yes.
The greater is the big one, the smaller is the smaller one. So sometimes we are actually, from the results of the other tests we talked about, the duplex scan, it determines if there's a refluxing, then we actually remove those two. So by removing those two vessels, or one of them that may be affected, that's what we call venous stripping. Now, sometimes you have seen people with like bags of worms on the feet,
yes.
on the leg and the feet, and then on the thighs. So sometimes we do what we call a stab avulsion. Stab avulsion means you go and cut at that point where you say bag of worms, and you remove those blood vessels, tie them out, and then you stab avulse, you go cutting at different points, but they eventually heal afterwards, and then even the scars disappear. So those are some of the modalities that we do here, and those are open surgeries. In other countries, they do endoscopic. They pass so many things in the vessels, and they operate within. Those technologies, we don't have them here, but they are available in other countries. So basically, we look at the medical. When the medical fails, then we proceed to the surgical. Okay. Now, those ones that cannot even fit in those two, medical has failed, but they cannot operate them, then they continue on conservative. whereby you tell them to use those compressive stockings for their entire life, wherever they are active or they are full awake. When they go to bed, they can always remove them. And then they keep elevating their leg or raising their limbs, and they proceed with life.
So Dr. Kabweru roughly has given us 3 main ways in which we manage chronic venous insufficiency. Has talked about the conservative means where we tell you, for example, elevate your feet for some time, put on compression stockings. Then he has talked about the medical where we are giving you particular drugs to have a given effect we want. We maybe don't want you to develop clots and all that, so we give you certain medicine. And then he has talked about the surgical. Dr. Kabweru, yes. How can I prevent chronic venous insufficiency?
Thank you very much, our viewers. Prevention of some of these diseases may look a little difficult, especially if we talked about that 90% of people who get them, they have familial exposure or hereditary. Then it becomes tough. But for the others that actually may acquire them because of their lifestyle, those ones are a little easier to prevent. One, before, especially for people who work long hours, travel a lot, and then standing a lot like us, the surgeons, we usually use these ambulatory stockings before we even get what? The chronic venous insufficiency. So we put on those long leg from down there up to the hip here. So long leg, compressive stockings are very important. But also when you, the other thing is that injuries, sometimes you cannot say, I'm going to prevent myself from getting accident, unless if your kind of work exposes you to injuries. Like if you are a surveyor, you are a builder, you are in the road construction and whatever, you try to avoid injuries if you're a driver. But you know sometimes accidents happen without your notice. So we should prevent those exposures so that at the end of the day, we are able to prevent what? Chronic venous insufficiency.
You're advising us to be more responsible.
More responsible. But you are not going to tell a pregnant mother, that, oh, please don't. No, people should become pregnant. But when they get those problems, let them come early, and then we tell them what to use from the very beginning. And then when the pregnancy is done, and you anticipate to get another pregnancy, they should come and we assess them whether we are able to put them on a specific modality of treatment before they can conceive and in which period. Then when it comes to people who have like pelvic uterine problems,
yes,
then those ones we should ask them that before they leave their fibroids to grow up to an extent that actually is unbearable. Because you have ever seen someone with a fibroid as if she's almost pregnant.
Yes.
Because the moment you leave them to grow to that level, then they will expose you to the other secondary complication, which shouldn't have been. So people should just take responsibilities, and we are there, by the way. When you come early and ask for what interventions we can do, it is always very easy to get the right preventive measures.
Interesting. Thank you so much, Dr. Kabweru. So for our friends out there who enjoy sitting on platters of chips and chicken and watching TV from morning till evening, we advise you to exercise, because a sedentary lifestyle is actually a risk factor for chronic venous insufficiency as well. Where can we get these services within Mulago Hospital?
Oh, thank you very much. So that division that actually I work with, it is located in New Mulago, Mulago National Referral Hospital, on Ward 2B, CTS. We run our clinic on Thursday, level 4, which is called the CTS clinic, and the patients can always come as early as 8, and they will be booked and we see them. So when there is need to be worked on, then we refer them to our clinic, or our ward, which is 2B.
Dr. Kabweru.
Yes.
I would like to thank you so much for the time you have given us and for the wisdom and knowledge you have shared with us. And certainly we cannot live without thanking our esteemed viewers for the time you have given us, for the questions you have kept bringing in. The story does not end here. Let us stay inquisitive. Let us keep asking questions that are pertinent to our health. And most of all, let us take our health as a priority. We thank you so much for your time. This has been the DOCtalk Show with your host, Dr. Muyanga and Till next time, thank you so much.
This message is from the Ministry of Health with support from partners.
UBC, inspiring Uganda.